All right. Welcome this afternoon. We're glad you're here, understanding and applying QAPI in everyday practice. You know, one of the most effective things that you can do is to chart your data that you're collecting, and it's really important to make sure that you're using the correct display of your data, because some of it, it might look pretty, but it is meaningless for you, and so you want it to have that shock and awe, especially when you're reducing things and, you know, you're looking really good or you're improving things. But, you know, if it doesn't mean anything to look at the data, then it's pretty worthless. It's just kind of a waste of your time. But there's different kinds of graphical representations, and the bar graphs are usually the ones that are used most frequently. And it is a graphical representation of ungrouped frequency data. And histograms is one of those ones, and if you've been in any of our QI projects for the last several years, you know that you've been receiving histograms along with your regular display of data of where you are in regards to your area of the network, and also where you stand with regard to the network overall data. And histograms are bar graphs that show the distribution of data. So it will tell me how many people are at a certain point along that continuum. Area graphs show how things change over time. And then pie charts is a percentage of a whole. So we need to make sure that we use the correct representation. And we need to make sure that we're using the correct scale. Now, the correct scale is, you know, if you've got all your data between 80 and 100%, you don't want the graph to go from 0 to 100. I mean, you end up with these wonderfully tall bars, but they don't mean anything because your data is only spread out over a 20% area. And then you need to make sure that you've got a measurement time interval. We need at least 3 data points in order to say we've got a trend. And so we need to make sure that, you know, we don't just start and have 2 data points and go, wow, look, we're doing really well, because you may or may not. And we'll show you an example of that a little later. And then, of course, you choose the proper graph format. And what graphs do is they assist us in making good decisions about what we're going to do with the area that we're focusing on for change. So, is your unit providing optimal delivery of dialysis care? Well, how do we know that? How would I, as an outsider to your organization, be able to identify that you're getting good care? You know, where's your proof? Where's your documentation? I like electronic medical records. However, there's a lot of stuff missing on there, and I can't see the whole picture sometimes when I look at your electronic medical records. So it's really important. You know, we used to chart by exception, so every time there was an issue, a problem, a change, we documented that. And sometimes I don't see that documentation being carried over onto the electronic records now. So we need to make sure that we're doing that. Otherwise, I don't know whether you're giving good care or not to the patient. And then if you're not documenting things, how do we know what's working and what areas of focus that you need to work on? It's really, really important that we be able to look at things and say, wow, look at this. And then, you know, it makes it a lot easier for us to identify areas that we might have to develop a QAPI on and start working on in the center. And can you, with looking at the data that you've got in front of you, can you discuss your facility's strengths and weaknesses? Do you know where there's areas that you need to work on based on what your data is telling you? And you should also be able to see your strengths. You should say, wow, we're doing really well in this area, not so well in this area. So that will kind of help direct you. So I hear 2 things a lot when I talk to facilities. I hear that, you know, we've got the oldest and the sickest patients, and we're never going to be able to change that. And so my question to you is, if that's the case, how are you documenting and addressing that as part of your QAPI? Because that's a barrier that you've identified that prevents you from improving your outcomes. And so that needs to be addressed. And with staffing an issue, the other thing I hear is we're short-staffed. We don't have enough staff. I'm working the floor today. I can't get to that. If that is an issue, again, how are you addressing that in your QAPI? Because if it's impacting the quality of care that you're providing, then somebody needs to have the discussion about perhaps we need to look at getting more staff or rearranging assignments so that the staff that you do have are able to cover everything that needs to be covered when it comes to delivery of care for the patient. So what is QAPI? QAPI stands for Quality Assessment and Performance Improvement. You know, it's more than just putting out fires. When we used to do QI, we used to be working along, and all of a sudden something would happen, and we'd go over there and we'd fix that problem, and then we'd go about our business until something else broke or something else happened, and then we would fix that. And that's putting out fires, and that's not what we're striving for. We want to do more than just ask why. We need to ask the questions, you know, what happened here? What happened that, and what particular thing occurred that may have contributed to the problem we're experiencing right now? And the idea is, how do we prevent the recurrence from happening? So that's why we have to look long-term. We do root cause analysis in order to identify those things and then try to fix things. And usually it's a system problem or it's a process that's not quite as good as it could be. It's not usually this person or that person that's just really bad at what they're doing. I mean, if they're that bad, that should be addressed differently. But it's usually a process or it's an overall organizational issue that needs to be corrected in order to rectify any kinds of problems that we might be seeing. So why is it really hard to do QAPI in a dialysis unit? Well, you know, when you're working with patients, your focus is on the individual patients that you're taking care of that day. You know, you need to make sure that the right prescription is programmed in the machine, that you're giving them the correct medication, that you've done that assessment on that particular patient, that you've done all your charting that you need to do. But administrators, they're not so much focused on John and Jane and Bill. They have to look at the overall performance, and so they have to look at the overall numbers. So it's what we call the aggregate number. So it's a collection of everybody's labs. So we come out with certain percentages for performance. And so that's when we're doing QAPI, we have to look at the overall focus. Because if we change a process, it's going to impact our individual patients. But the focus is on the general processes that oversee the whole population that we're dealing with. Since the conditions for coverage came out in 2008, the role of the medical director has been more defined. You know, it's kind of nebulous. Maybe we saw them once a month when we had a management meeting, and we didn't see them again. You know, maybe in your institution, maybe you have docs that are there all the time, that round all the time. They maybe have their office right in the facility. That's not generally the norm of how we interact with our medical director. But they are actually responsible for the QAPI program that you have, and they have to make sure that it's developed and implemented and maintained and evaluated. Doesn't it sound like nursing care planning? We always use and learn those same terms along the way. But it's the medical director's role to make sure that you are providing quality care to the patients. They have to make sure that the facility is achieving the clinical outcomes. And they also have charge of the oversight of the attending physicians. So if you're dealing with individual nephrologists and you're having problems because all of their patients, you know, you're just having this one issue with this group of patients from this one nephrologist, go to your medical director, because it's up to him to go to that physician and say, hey, you know, there's these outcomes are not as good as they could potentially be. So that's what they're there for, and you need to utilize them in that way. They're, you know, they has to control the process for involuntary patient discharge and transfer now. Remember, it's not just the patient's physician that has to sign off on a discharge, but also the medical director has to sign off on that discharge as well. So they need to know what's going on in the clinic that they're overseeing. And then it's up to them to make sure that your facility is participating in network activities and pursues the goals that we have set, because the conditions say that you have to work towards achieving network goals. Now, there are some steps in performance improvement. First of all, you've got to get the team together. Who is going to work on the project? Now, you know that when I sent out information, I asked for someone to be a lead on that. That doesn't mean that they do all the work. That just means that they have to oversee the team that's working on it, and they have to make sure that I get everything I need when it's due. So that's what a team leader does. But that doesn't mean that only the team leader is the one that's working their butt off and nobody else is participating. So you need to make that perfectly clear. And then you have to prioritize what you're going to be working on. Now, you've had the opportunity. There were 5 different clinical measures in this project, and you could choose one that you were having problems with, and just pick one to work and focus your QAPI efforts on. And what we're hoping that you'll do and get from this is that you will learn how to do QAPI, and so that you can apply what you've learned in the project that you're working on, and you can apply that to other areas should you fall back on in those other areas, so that you'll learn how to do the whole process, and that way maybe you'll never have to be in another QI project. The other thing that you do is you explore root causes. And we're going to take a look at some of the tools that you can utilize, and we'll give you some resources of where you can find those tools to use. But you have to kind of dig down and figure out what's the core of the problem, as opposed to, yeah, we've got this problem here and that problem here, but you've got those problems because there's something else wrong. And so you have to get down and find out what it is that's the base cause of all your problems and make an attempt to correct that, and the other issues will correct themselves then after that. Then what you do is you develop your action plan, and then you implement it. And, you know, I've gotten some back already, and I must say some of them are just fabulous that I've been reviewing today. So you need to get that started, and then that improvement plan tells me who in the group is going to be focusing on certain areas and certain aspects of your action plan. And then, of course, you need to monitor and report the progress. Now, this is done at your QI meetings. So, and this may be what the lead person does. They get their information or they get their reports from the other team members on how they're coming on their task areas that they're working on, and then they give this report to the QI committee. Now, because this is such a short duration of a project, it's 6 months in length, you don't want to report to the QI committee once a quarter, for instance. You really need to be reporting what's going on in your QI activity on a monthly basis, and hopefully your QI committee meets on a monthly basis. Sometimes when you meet, you don't necessarily discuss every single thing. There are some things that are quarterly that you review. There are some things you review annually. But for when we do rapid cycle improvement, it has to be monthly or even more frequently. And then it has to become part of your medical records, of your minutes. So your QI committee minutes that somebody's taking needs to incorporate any QAPI activity that you're working on. And it should have a statement in there about what's happening. You know, you've started it, or for instance, your report, you know, if you meet next week, for instance, that you attended the kickoff of this project, you received the tools, that you attended this educational WebEx, and that you've created your action plan, and you've assigned these people to this. And then, you know, you can give other information if you've got it available, or if that's as far as you've gotten when the meeting occurs, then that's how you report. And then every time you come back, you add on new things that you that way, if the state survey agency comes in and they take a look at your records, that they'll be able to see that you're actively pursuing the goals of the QAPI that you're working on. Now, you want to review your current QAPI documentation. You need to make sure, are all the required QI indicators included? Because there are certain ones that CMS says you need to look at. Do you have goals set for all of your QAPIs that you're doing? And is somebody reviewing those trends? So the same person doesn't have to be in charge of multiple projects. As a matter of fact, you should have different people in charge of different ones. That way you can kind of spread the learning process around, so there's lots of people who get a good understanding of how to do QAPI. And then have you prioritized your indicators? CMS has lists of things that, they tell you how you go about prioritizing, and then they tell you the ones that really need to be worked on immediately if you've got indicators out in those particular areas. Then, is an action plan needed? If there's something that, for instance, you have to buy new equipment, do you need an action plan for that? Probably not. Somebody's going to place an order. We're going to find out when it's going to be received. It's going to show up. And unless you don't, if you don't need to train somebody on how to use it, say it's a chair, for instance. If you don't need to train somebody on how to use that chair, then it can just be put into place and put into action, and probably doesn't need an action plan. But if it's one of those newfangled ones that has lots of different gadgets and gizmos on it, then perhaps you need to have a plan of how you're going to educate all the staff so that nobody gets hurt when they use it, or so, in the event of an emergency, they can get it to work right. And then, is the interdisciplinary team involvement documented? It shouldn't be that Sue has done it all. All right? You want to say who's on your team and who's working on things so that they can see that. Because usually, if you're going to do a whole big project and you only have one person working on it, it's probably not going to be the best project. And so, and this person's probably killing themselves trying to do all of these things when you really need to include some other people in that. So, how do you go about setting goals? Well, there's several ways that you can do it. CMS sets performance targets as well as the networks. And CMS has also designed a document for the state survey agency called the Measures Assessment Tool, the MAT. If you don't have a copy of that, it's on our network website under the conditions for coverage. And I believe it's under survey and certification that you'll find it. And it's version 1.8. So if you have an earlier version, they have updated it since then, so you'll need to replace it with the most current version. We usually send out e-bulletins when they come out with a more current form, and then we replace that and put it on our website. You can also compare clinical outcomes. You can look at previous years, so you can look at over the last 5 years, how have you looked on this clinical indicator. You can look against other facilities in the network. When we're doing projects, we usually send out graphs, and we've broken it down since, for instance, for the state of Washington, it's so big that we usually have Eastern Washington and Western Washington, but we also have Seattle-Tacoma area. So and then we tell you what region that you're in so that you can look at it, because if we put it all together, it'd be so scrunched up you wouldn't be able to see anything. It would look like one piece of colored paper. And so for Portland, we do the same thing. We have Portland, and then we have the rest of Oregon. The other states, you get the whole state when you're looking at it. And you can also look against national benchmarks. For the most part, especially for Fish in the First, for instance, we have the national benchmarks set for incident patients, for prevalent patients, and for catheters greater than 90 days without any other access. So this is what the conditions for coverage say about quality assessment and performance improvement. First, the dialysis facility must develop, implement, maintain, and evaluate an effective data-driven QAPI program with participation by the professional members of the interdisciplinary team. So who is that team? Well, it could be your medical director, a nephrologist, nurse, facility administrator, a technician. If you've got reuse, it could be somebody from the reuse department. You could have your secretaries, your data coordinators, if it involves, if they're going to be part of the data collection or they're going to be creating your documents for you and things like that. So we need to make sure that we do have somebody from just about every area in the facility. These are the quality indicators from the measures assessment tool, and the V number and then the number after that, those are the V tags. So if you looked in the conditions for coverage and you looked in the guidelines, the interpretive guideline, you'll be able to find exactly what this has to say under each one of these areas. But for adequacy, for instance, you're supposed to be looking at KT/V and URR, nutritional status, albumin, body weight, bone disease, PTH, calcium, phosphorus, anemia, hemoglobin, ferritin, vascular access. You're supposed to be working on increasing fistulas and decreasing catheters. Medical errors, you're to decrease frequency of specific errors. Reuse, you need to decrease adverse outcomes. Patient satisfaction, you need to increase those survey scores. And for infection control, you need to decrease infections and increase vaccination status. So these are the ones that you need to be looking at specifically, and if you're deficient in any of these areas, there needs to be a QAPI on them. If you're doing well in certain areas, then you wouldn't have to focus on that. But you do mention that, for instance, if you've got a really high percentage of patients with albumin greater than 4, if you're using the green method, for instance, then you would just state that, and then you would move on to the next quality indicator. Now, this is what the conditions say for considerations and prioritization. It says you need to look at the prevalence of the problem. How big is it? What's the scope of this issue that you've identified? And how severe is it? Because if it's really severe, you really need to be working on that immediately and as quickly as you can. And then you need to look at things that impact clinical outcomes and get working on those as well, and also those that impact patient safety. When they say for immediate correction, these are examples of serious health and safety threats. These are the things that if they are really a huge issue in your facility, you'll be put in immediate jeopardy, which means you may have to suspend dialysis and send your patients elsewhere until you get it fixed, retrained, recertified, that everything's okay. So safe water or dialysate, defective clinical equipment, unsafe reprocessing of dialyzers, epidemiological risks, insufficient number of competent staff to perform scheduled treatments. That means to preserve accesses, to monitor patients, and to ensure safe machine function. So how are we going to use the data that you've been collecting? And we're going to take one specific example and walk through that to help you try to understand what it is that we're looking for. So you can see the adequacy. This table runs from January to August, and so we've got more than 3 data points, so we should be able to get a good look. The goal is listed. For instance, hemodialysis adequacy at KT/V greater than or equal to 1.2. The goal is 94%. And then hemoglobin's 10 to 12. The goal is 70. Hemoglobin's less than 10. The goal is less than 10, and so on. When you do this, we're focusing on the aggregate, remember, not on the individual patient. You can't see an individual patient in this tracking form at all, in these percentages. And this is the percent of patients that are meeting this target goal. So remember, it's not about the individual patient, but it's about the overall percentage of those people actually reaching your goals that you have set. So let's take a look and see how we can be successful at doing that. let's start with root cause analysis. What is the definition of root cause analysis? Well, it's finding the real cause of a problem and dealing with it rather than simply continuing to deal with the symptoms. So I always say no Band-Aids. And what am I talking about? Give an example. Here's a good example. When we are having problems with the catheter and we decide to reverse the lines on the catheter, where and when did it become a standard in dialysis that it was okay to run them day after day after day with lines reversed? Because that's just a Band-Aid. Because that's telling me that there's something wrong. Either the placement is wrong with that catheter, or that clots are forming in that catheter, or around the outside of that catheter wall that's preventing me from running that catheter in the right direction. And our clinical practice guidelines say that you can reverse lines emergently one time in order to get through that treatment that day. But that is an indication that there is a problem, that there is a dysfunctional catheter now. And instead of us working on trying to fix that problem, what we do is we just keep a way of keeping that catheter running. But eventually, that catheter will fail, and it will completely clot, and then that patient's going to lose out on dialysis time. They may not get a treatment that day. You're not going to get reimbursed for that patient for that day, and then they're going to have their catheter changed out. When we could have been doing something as soon as we found out we were having difficulty with that catheter to try to correct that real cause of the problem. So we want to make sure that when we're looking at things that we're not just using Band-Aids. There is one root cause analysis method called the 5 whys. And you can see that there's a mouse in the cheese, there's a mouse in the house, the screen door is open, we put out the cat, somebody left the screen door open, and they have a screen with a spring latch on it. Now, if we focus on the mouse in the cheese, a Band-Aid would be, we set out a mouse trap and we catch that mouse. Therefore, we've taken care of just that one mouse. But is that going to stop other mice from coming in the house? No. It's only going to stop that one mouse from coming in and getting the cheese. So that would be a Band-Aid to set a trap for that mouse. So you have to say, why is there a mouse in the cheese? Well, because there's a mouse in the house. Well, why is there a mouse in the house? Because the screen door is open. Well, why is the screen door open? Well, because somebody put the cat out and they left the door open. Well, why did they leave the door open? Well, we've got a hard time. Sometimes it's hard to train somebody to close a door, right? So what you do is you put on the screen, you put one of those spring latches so that every time the door opens, it will automatically close. And when we get the door to close every time, then we don't have mice coming into the house through the door, and we won't have mice in our cheese. So you can see how anywhere along that line, we could have put a Band-Aid, but in order to fix the problem is that the screen door was open, and that's why the mice were coming in and getting into the cheese. So that's what 5 whys is all about. Because they say you need to ask why at least 5 times to get down to the root cause, to the real reason that there's a problem going on. You can also use cause and effect diagrams. So you've got these causes or different categories, and the effect is what's your problem you're having. And we'll take a look. Here's a root cause analysis that's been done for reducing central venous catheter infections. So the causes could be the patient, the equipment, the caregiver, or the environment that's causing catheter infections. And so under each category, then you list the causes under each one of those. So for a patient, for instance, with poor hygiene can contribute to catheter infections. Perspiration under the dressing, nasal carriage of Staph aureus. They manipulate the catheter at the exit site. They remove the dressing once they get home. They shower and get the dressing wet. They sneeze on the exposed site. Or the dressing comes off due to activity or sleep. And this is what your team does. Your team sits down and you brainstorm all the reasons, all the patient reasons why you could have a catheter infection. Then you can move on to the equipment, and you can see, well, the surgical procedure. You know, if a doctor breaks sterile technique, then we've got a problem. Cracked caps can allow bacteria to get in. Improperly fitted caps, if they don't get screwed on correctly, they're contaminated supplies. And then you can go to the other ones, like caregiver and the environment. So then, when you see you've got a whole lot under one, it's like, maybe this is where we need to focus our work and make some changes. So that's how you effectively use a fishbone diagram. So, root cause analysis, we use tools to collect aggregate percentage of patient data. We want to go for the biggest bang for the buck. You know, we have very limited resources, and even the networks, you know, we try to find a project that we can do that will have a major impact on what we're doing, and we have to try to do it at the least cost for us because we have a limited budget, just like you have a limited budget. But you want to try to find a way to reduce problems or save on cost or, you know, increase patient satisfaction by finding that area that you could focus on. And just sitting here compiling excuses is not doing root cause analysis. So you just want to remember that. So now let's take a look at these quality indicators. And if you want to participate, take your phone off of mute, hit *6 to take yourself off mute, and we're going to look. We've got the hemodialysis adequacy, K/V greater than or equal to 1.2. The goal is 94%. So over this 8-month period, have we met this goal for adequacy? Anybody? No. Okay, no. How about hemoglobin 10 to 12? The goal is 70%. How are we doing?
Just August.
That's August, right? So, no, but it looks like it's going up, though, except for February. Something happened in February, but we went 66, 63, and then, look, 67, it kind of stabilized, then it went to 68, and that's to 69, and 70, so hopefully, but remember, we need 3 data points in order to say, you know, we've kind of reached this and met this, and so we're not quite there yet. How about the hemoglobin less than 10?
It's spiked up in August.
Okay. Yeah, for some reason it climbs back up there, but the goal has still been met. We're still under there, but you're right. I would keep an eye on September to see what happens, because if it continues to go up, if it goes up to 10, we're gonna be right at that point where we're going to have problems there. And so you might want to take a look and try to find out what happened between July and August that caused that to go up 4%. And then implement something right there at the, you know, once you get your August data back and you go back and take a look. And then make some change depending on why you think that you had that 4% increase, and implement a change at that point so that we don't get to 10 or above 10. Now let's look at albumin greater than 4, 0.0 or 3.7, depending on which assay you're using. The goal is 35%. So how are we doing?
Looking good recently.
Yep, it looks like we're right at goal for 3 months, and then we had just a little dip here in May. But look, we had April and June and July and August, so we're right at goal. So, but you know, if we've got some sick people, you know, come back from hospitalization, or we get some new patients coming in, and, you know, we get 5 or 6 new patients in 1 month, that can have a profound impact on that albumin. So we want to try to get above the goal if we can, so that when we do get 1 or 2 patients in there, they won't drop us down. And let's look at the catheter rate. The goal is less than 10%. How are we doing?
Not good.
Not good at all, are we? although it got a little better here in June, and it looks like it's starting a downward trend, it's still considerably higher than what we're hoping to as far as the goal goes. So, which indicators of these will you choose to work on then?
Catheters.
Catheters, what else?
Adequacy.
Adequacy, and what else? How about this one here? Because we're not there yet for a long enough period of time. And you know, a lot of times this one, the catheter one, has implications for adequacy and for hemoglobin, doesn't it? So if we can focus, and if you're going to work on one, you know, sometimes it takes longer than a 6-month period to work on catheters because, you know, we have to get another access plate, it has to mature, and we have to be able to utilize it and then get that catheter removed. So it becomes difficult, and when you're looking at rapid cycle, you really do have this project going on, but it may not be the one that you're going to see a change tomorrow in. Whereas adequacy, you might be able to, and hemoglobin, based on adjusting a protocol or having conversation with your doctor or your medical director, that you could have an impact in the following month or 2 months down the road. All right, now let's look at an action plan here. This is facility X, Y, and Z. And remember, the adequacy goal was 94% of patients to achieve a KT over V greater than or equal to 1.2. But the last 8 months, they were below goal. So they think that this is the area where they need to target. And so team leader, I'm a nurse. So she's the one that's going to be responsible for making sure that that they're working towards reaching that goal. So the goal is that 94% of patients will achieve the KT over V of 1.2 by November the 30th. Now, this plan was initiated in August 31st. So we're looking at a very short time period. We're looking at 3 months. And then the percent currently at goal is 90%. So what they need to do is move this process from 90% to 94% in 3 months. So they've identified the interdisciplinary team members, Dr. Doolittle, the nephrologist, Lisa Labb, the dietitian, Cindy Social, the social worker, and I'm a nurse who is the nurse manager there. So when they did their root cause analysis for this adequacy problem, here are the 2 things that they found. And they found that, number 1, treatment duration was not being met. So they obviously did some kind of a chart review and were able to find this out. And they also found problem number 2 is that the blood flow rate was not met. And when we look at the treatment duration, 62.3% of the patients weren't on according to the ordered time. And then the blood flow rate in 43% of the group wasn't met either. So right there, you're looking at a substantial number of patients that will have a profound impact to be able to move that 4%. So when they developed their action plan, this is what they decided on that they would do. Number 1, they'd create and distribute education for patients regarding coming off dialysis early. Now, if it's a patient issue, yes, you need to do that. And you should be able to see, because in your charting, when you're doing chart reviews, it should say that the patient requested to come off early. And if you don't document those things, remember we talked about documentation not being there. You need to document when somebody comes off early because you're not completing the prescription as ordered. If the patient's ordered for 4 hours, having them dialyze for 3 hours and 50 minutes is an error. They need to dialyze for 4 hours. Who's the responsible person? Well, Betty, she's a staff nurse. She's going to be responsible for creating and giving out this information, this education piece to the patients. When is she going to start? She's going to start on September 10th. And a checkpoint date is you want to look ahead of time before you think you're going to finish, and you want to make sure that you're going to keep on schedule with things. Because we know that stuff happens. We know that flu season is coming. And we know that sometimes we lose 2 or 3 staff people to flu, and we really have a hard time just getting through the regular course of taking care of patients in a day when we're down 3 staff people. So the checkpoint is really good. I mean, we have all the good intentions, but all of a sudden half your staff is missing and nobody can get away to go to an in-service, or nobody's available to hand that information out and explain it to the patients, then it's not going to happen, or we're not going to get it completed. And it's going to be postponed and postponed and postponed, and finally it's not going to happen. Or it's going to happen so late that it's not going to have the impact that we wanted it to have. So she started on the 10th, and she finally completed it on the 15th, and she said all patients received the education without coming off early. Now, if the problem isn't the patients coming off early, but too many patients are coming off at the same time, then that's a scheduling problem that falls on nursing. That has to be adjusted. It's not okay to have 2 staff and 3 patients coming off at the same time. Because one person always ends up getting a little longer treatment, somebody comes off on time, and somebody gets shortchanged on their treatment time. And that's not appropriate. That's not an appropriate way to take care of patients. And so if that's the case, then you have to look at staffing, and you have to look at the patient's schedule and see if there's some way that you can switch those patients' times around so that they don't all come off at the same time. And that's the way that you have to focus. It's not about you, it's about the patient. And we have to make sure that you're functioning in that light, that it's about the patient. So, number 2, they decided that they needed to do education for the staff on following the prescription, on the length of the treatment and the blood flow rates. And the education department is going to take that on. And so they're going to start on the 12th of September, and they're going to check in 3 days later because they've got their program all ready to go, and they want to make sure that everybody gets a chance to participate and to attend this training session. And it took them 8 days to get all the staff trained, but they did complete it on 9/20. And remember, any deviation from the ordered blood flow rate, anytime you turn down a blood flow rate, there needs to be documentation in that medical record on why you turned that blood flow rate down. And why that patient came off at a time that was different than what was ordered by the physician. These happen to be a huge problem. And if you can adjust this problem and get the patients to stay on and give them the full length of their treatment at their ordered blood flow rate, guess what that's going to do to adequacy? That's going to profoundly impact your adequacy. The alternative is that the doctor's going to increase their treatment time. That makes a lot more work for you to have to add 15 minutes or half an hour to somebody's treatment time. When, if you were following the prescription as it was written, that perhaps they wouldn't need that to happen. And then number 3, that Ima said that she's going to do a chart audit. She's going to do 10% of the daily treatment records each week, starting on 9/26, and she's going to do it for 6 weeks. So her start date is 9/26. Her checkpoint date is 10/7. All right, and so you can see it's not completed yet because today is the 7th. So she's checking in today to see how well she's been able to get through the audit. Because remember, things happen, meetings happen, conference calls happen, staffing happens, and so, but she's got that checkpoint date of today, and then she still hasn't completed that, the process of doing the chart audit. And when she does get that done, she'll report that in the QI minutes. And then you'll report that all the patients received education and all the staff got retrained on length of treatment and blood flow rate. And then hopefully that when they go and you do your monthly lab then and you check the adequacy of the patients, that we've seen that we've moved towards reaching that 94% goal. So that is how you put together an action plan. So, the PDSA, the study part, what is rapid cycle improvement anyways? Well, we have to take a couple of things into consideration. We have to rely on what we know as far as existing knowledge. We pretty much can figure out if we've been working the same shift with the same group of patients for several months, we kind of know what issues are cropping up. And so I can contribute that knowledge to the group so that we don't have to try to figure it out. We already kind of know that it's there. This dramatically shortens the discovery process. And then we can work on, you do a rapid trial and learn method. And you have to put something into action. That's what rapid cycle is all about. You decide, okay, we're going to change this. If you're going to readjust patient schedules to try to make sure that they don't all come off at the same time, then you're going to let the patients know why you're going to do this, when you're going to do this, to make sure that they get their good dialysis treatment. You give them the rationale for why you're doing that. But you're going to do it quickly, and then you're going to see, and you might do it in one treatment area to see if it has that's actually what's causing your problems and why there's a shortened treatment time in this one area. And so if that works, yes, this is the real reason, and this is a good way to, this is a good solution. And so then what you do is then you can spread it to your other treatment areas, or you can apply it to everybody. But rapid cycle, it's usually you pick a small group and you do it. You might want to do it on first shift, for instance. Or you might just want to do it on Tuesday, Thursday, Saturday, because you might have a smaller group of patients then. So however you choose to pick out how you're going to do this little short trial, and you know what, if it doesn't work, then you got to figure out something different, and you try it. So that's what that rapid trial and learn method is. So that's what rapid cycle improvement is all about. So you make one change at a time, and then you trial in a small sample. So the ACT part of PDSA is that you have to monitor your performance improvement. And the conditions for customers say you must continuously monitor the performance, you must take action that results in performance improvement, and you must track to assure improvements are sustained over time. So the question is, how will we know that a change is an improvement? Well, you're going to use sampling, and so you're going to get that measurement. And it usually requires more than one measure. And then you need to balance those measures to help assure that the system is improved. Remember, we said it was usually a system problem and not an individual patient problem. And then we plot that data and measure it over time. So here's some tracking tools, for instance. If you're working with the management of patients with central venous catheters, and it's a step-by-step on what you should do, and you answer yes or no to questions. And then if you answer yes, then you go in one direction. If you answer no, then it gives you a different. So it's a decision tree. And it will kind of help you to get rid of those catheters, reduce catheters, and get them out and have a permanent access and patient. If you're working on your long-term catheter, if that's your area that you're choosing to work on, this is a good tool to use. Access infection flow sheet. This has a place for multiple patients on one sheet, and you can track them. So it could be any of your patients. You can see PD catheters are on there, port accesses are on there, catheters, grafts, fistulas, the symptoms. So it's a nice, easy little check box, which makes things really quick. And then the culture organism, and what the treatment plan is, what antibiotics you're giving, how frequently you're giving them, and then what the outcomes were for that particular thing. And so it's this is a monthly sheet that you can utilize for patients who have access infections. Now, to look at the danger of comparing two data points, we're going to look at peritonitis episodes per year. And so we've got January of 07 and January of 08, and the average is 3.5. So when we look at this, we can see that they had really high episodes of peritonitis for 7 months there, and then something happened. And I don't know what happened, But by my looking at this graph, I know you did something. You implemented something, you changed something. Because it significantly dropped from July to August, and you were able to sustain that over time. And you've got 1, 2, 3, 4, 5, 6 data. So that tells me that that's a good positive trend down there, that whatever change was made in July worked. Now, in this facility, they ended up with the same outcome, but the graph looks very different. And so if we just looked at point A and point B, we'd see that, oh yeah, look, they made this nice change. But now they did something here over time, and it gradually dropped that rate down. And this isn't a bad thing, but when you want to see, when you've identified something that really was a key thing that caused your infection problems, like facility A, that you can tell that whatever change you did had the impact that you were looking for. And then here's facility C. Whatever they did, they couldn't sustain. So they were able, between January and March, they were able to drop. And it was a significant drop. However, when April came around, it bounced back up almost to where they started from. And then in May, they did something again, and it dropped back down. And then you saw it started to finally climb back up, and then it dropped back down. So whether one particular person was taking care of that patient, and then they were taken care of by somebody else, or there was a break in technique, that the patient was doing, and then they got retrained, and then it stopped, and then it dropped. I can't tell from here what happened, but whatever it was, it didn't work over an extended period of time. So this is, if you don't know about the NHSN website, this is where you voluntarily put in your catheter infection, your access infection. And you can see when they started, in the first month, they had a significant drop, but then it bounced back up again. So, again, whatever they did, it didn't work. It sustained. And then it went back up, and then it dropped back down in months 4, 5, and 6. But then, again, they had another spike, and it was a really high spike, and they did some kind of a change. They must have implemented some kind of a change. It dropped it back down, and look, 1, 2, 3, 4, 5. For 5 months, they've had no positive blood cultures. So whatever that change was done in month 7 had a profound impact on their infection rates. Now these are, if you're in charge of the facilities, you've probably seen this from our data department. This is the compliance log, and remember, reporting your data to the data department here at the network, the Medicare standard is 90%. That's the expectation that you'll be 90% compliant in getting your information in. And this is from 2005 to 2010. And what this one shows, and these are bar graphs, is that there was a corporate person completing these. And they did a fairly good job. I mean, most of the time they were above 90. But then they decided, after the green bar there where it says 94, they decided to give it over to the individual facility to do their own reporting, their own compliance reporting. And as you can tell, they didn't do a very good job because it just kind of plummeted over time there. And so they weren't able to sustain anything. But right now, just looking at that graph, I can't tell you what happened except that I asked the data department why this graph was the way it was, and they told me what was going on. Now we look at this one. This one, an individual person was reporting the data to the network and wasn't doing a very good job. And what they decided to do, because they were put on they had to create an action plan for how they were going to improve their compliance, they took it to heart as a group, and they decided they were going to provide some assistance to this individual. And when they enacted that action plan, look what happened. We've got 6 points there. 5 points tell us it's a positive trend. We've got 6 consecutive reporting periods that they were well over the 90% standard. And so this is an example of how implementing an action plan can have positive results. Now, this is a monthly catheter tracking tool that we use in our catheter reduction projects. And we've got blue bars and green bars. And the blue bars are total catheters in your facility. And the green bars are the catheters greater than 90 days with no other access. And you can see that over time from January to June that they nicely started to get rid of their catheters overall, but especially their long-term catheters. But just because we've come to the end of 6 months, and you'll come to the end of your 6 months, it doesn't mean you just stop tracking this now, because we need to be able to sustain our change. You know, the results need to be sustained over time for true change. And just because your measurement period is complete, you don't stop that monitoring, because this is what happened after that. All of a sudden, you start to see the total number of catheters rise, and the number of long-term catheters are starting to creep up again. So they didn't sustain that change that they achieved when they were in this QI project. So what does it mean for your facility? Well, you need to refine your processes for QAPI. You need to engage the staff. People kind of need to own this. I know it's work, but, you know, if you take a look at how you can change things and you can incorporate that as your practice, your new practice standard, then it's not that hard. You need to review your processes regularly. You need to intervene quickly. And you need to have a good understanding of what root causes are and what barriers are. And then you have to design whatever you're going to do, those strategies that match the barriers. And then you need to track that data. You need to change your culture in your facility. You know, just saying, oh, you know, we can't do that, or I don't have time to do that, or I don't want to do that. That's not a good attitude to have. We need to have a positive attitude about this, because down the road, the reimbursement that you get for the dialysis that you perform is going to weigh heavily on what you do with your outcomes and how you take care of those patients. So you need to evaluate the processes, whether it's policies or procedures or the equipment that you're using. You need to determine the barriers to change, and staff could very well be the barriers. And you need to identify ways to overcome those barriers. You need to incorporate best practices. And then we need to create an environment of collaboration. We all need to work together in order to drive these changes and to improve the outcomes. There's lots of resources out there. The Agency of Healthcare Research and Quality, the American Society for Quality, the Forum of ESRG Networks has many toolkits. The Institute for Healthcare Improvement has their tracking tools are free to do root cause analysis. The National Renal Administrators Association and the Renal Physicians Association also has QI products on their website. So there's lots of places to get information that you need to do QAPI. These are the references from today's talk. And now, if you have any questions, please don't identify yourself or your facility, but if you have a question and you're muted, hit *6 to unmute, and you can ask the question. And what you need to do is there'll be a poll that will be popping up on the screen. Before you hang up, please take a minute to fill out the poll. I think it's only 4 questions. I would appreciate that. And does anyone have any questions?
You use examples as far as projects to work on. Now, one of the projects that I thought we could work on was AVS, right?
Yes.
Okay, because that was listed as one of those 5 that you had up there, so I wanted to be sure that was okay.
Oh, yes. You've got your, you should have your report sheet, your data reporting sheet, your monthly report that you're going to turn in. And if you can either work on increasing AV fistulas, decreasing long-term catheters, working on suboptimal hemoglobin, working on albumins, and working on adequacy.
Okay. All right. Thank you.
If more questions, I want to thank you very much. Please make sure you complete your poll before you hang up. And thanks a lot.